Hello, and welcome back to Compassion in a T-shirt. I'm Dr. Stan Steindl. Today I'll be speaking with Dr. Rebecca Poz, who's a clinical psychologist and neuropsychologist working in the NHS and in private practice in the UK. In particular, Rebecca provides assessment, rehabilitation, and psychotherapeutic interventions for older adults. In fact, she's developed innovative ways to use compassion focused therapy for older adults, and we'll go on to discuss a paper she's published which explores the evaluation of a compassion focused therapy group for couples experiencing a dementia diagnosis. It's an inspiring conversation, not least reminding us to bring compassion and self compassion for those in older age. And so I bring you Dr. Rebecca Poz. Dr. Rebecca Poz, thank you very much for joining me on Compassion in a T-shirt.
Thank you for the invitation. It's very nice to be kind of gotten out of bed at, crack of dawn. It's not really the crack of dawn, but, with the time difference between you and I, it's lovely to start the day doing this.
Yes, you have your Friday ahead of you, whereas I've kind of hit the weekend, which is very nice. Yeah, I suppose. I mean, you have many interests, actually. I think it's been interesting to just sort of read up a little bit about you and your work. I mean, in terms of everything from neuropsychological assessment and rehabilitation, through to psychotherapy, through to education programs with school kids about dementia and those kinds of things. But I guess with a particular focus on older adults, really. And I'm especially interested to hear a bit today from you about that, about working with older adults and around things, I guess, like aging itself, but mental health amongst older adults, perhaps specific things like dementia and so on. But yeah, but specifically through that compassion-focused lens and where maybe compassion and self-compassion might fit in. I wondered though if we could start by perhaps if you could talk a little bit about just your current work and particularly the work you do with older adults. Tell us a bit about all that first of all.
Okay, cool. So I work 4 days a week in the NHS, so in the National Health Service over in the UK. So that I'm sure most people know what the NHS is, but it's available for people free at the point of access. So, so I work for Norfolk and Suffolk Foundation Trust, and we provide the mental health services across the whole of the east of England, across East Anglia. And so my role there is to a kind of particular region, West Suffolk, and I've got a couple of mental health teams, community mental health teams that I work into. We've got some assessments, so memory assessment teams, dementia intensive support team, and then we've got an independent ward as well for people who might need to come in for more supported wellness, I guess. So yeah, so I've been doing that since I qualified. So I qualified back in 2001, and I've been working in the NHS since then. But I've always, it's great because there's more than 4 days a week in the working week. So my fifth day, I've always done something a bit different. So today I work into a neuro rehab unit. So that's for adults of any age over 18. So there often are more older adults in that setting who've maybe had a stroke, but also younger people who've maybe been on the front end of a road traffic accident or something like that. And so having rehab there. So yeah, so I provide into the older adult service therapies, but also some neuropsychological assessments, some rehabilitation in that setting, and then quite a lot of supervision to other people and a little bit of kind of, I've got a very tiny clinical director role for quality and associate clinical director, but what do these labels mean? Who knows? So it means I get to poke my nose in and go, oh, I think we could be doing these things a little bit better or differently. What do you think? So that's kind of a bit of a summary of what my working looks like.
I noticed you posted, I think it was a report from a charity, Age UK, I think it was, who recently sort of reported on a survey, and I noticed in there that they kind of included 50 plus in their statistics, and I'm 52. I wondered though, and I thought that was good and interesting, and it is interesting to see even the 50 to 59-year-old age group and some of the challenges they perhaps face, and of course beyond that as well. But how would you sort of define older adults, or I'm not even sure if that's quite
Mm,
the right question, but what are we really thinking of if we're sort of thinking of the kind of area that or the people, I guess, that you're working with?
mm. It's a really good question, isn't it? Because at some levels you have to have a number, often for commissioning purposes. What age does this person need to be in order to access this service? And so it can be quite black and white, and they can be, commissioning around age 65 or age 70. But often it's more of a conceptual thing that we're working to. Of what does it mean to this person to be experiencing their life in the way that they're experiencing it in this moment in time? So are there particular psychosocial struggles that maybe would be more typically associated with later life? And then are they best served and best looked after in this particular pathway?
Mm.
And often I throw out to the people that I'm kind of working with or training, as in training and working with, and say, what does aging mean, and when do you get old? Can you tell me what date is it going to be that you get old, and what does that mean to us? And there's something around the fact that it's a very socially constructed issue, isn't it? That if you're a professional footballer, you might be old at 35. If you're, a Tai Chi master, you might not be old when you're 70 or 90. And so it's very much about, I think, about how we look at ourselves and how society looks at us to say, are we still useful? And there's something, I think, about that sense of usefulness to the wider system that can often lead to people feeling ejected at earlier or later points in life. But I suppose when we're thinking of what might be coming up for people, there might be different issues in terms of physical health, in terms of social engagement, in terms of roles. So those kinds of things. And often that comes, sort of age 65, 70 plus, when people are, kind of, again, socially constructed, that we start to say, right, you should no longer be in the workplace. We'd like you to, sit at home on a sofa or whatever that might be. But it can happen to people much sooner in life. And that might be because, for example, somebody acquires a neurodegenerative disease earlier on in life. If you have a younger onset dementia, it might mean that you're going through those life transitions and coming up against snags and difficulties and challenges that, if it wasn't for the fact that you had young onset dementia, you probably wouldn't meet for another 20 years. So,
Mm.
yeah, so I think, does that answer the question?
It's actually a wonderful answer, because it's a kind of a it depends type answer, isn't it, in a way? But it is that, people, partly it's a little bit to do with how one perceives themselves, their own sense of their identity, the roles that they play, where they maybe feel that they fit in society, or how, whether they feel kind of useful in that sort of sense. It also relates a little bit to a societal or social construct of where there's this kind of assumption socially of what it might mean. It's also very individual, because it can depend on random things, health related changes, things that might happen at different ages but still create certain challenges of something like the older age, or that sort of thing. And so it really does depend. It's hard to put an actual time point on it. I mean, I
Mm,
not to talk about me too much, but turning 50 was kind of interesting, because on the one hand, it felt kind of liberating, because like, I don't have to kind of worry what anyone thinks anymore. I do a little bit still, but there was a kind of a freedom there, and yet on the other hand, I do notice different aches and pains now, that the body's not the same as it
mm,
once
mm,
was, and you sort of start to get a bit confronted almost, I think, even now at the changes that are happening.
mm. And I think what you're summarizing there is the fact that pretty much all of these things are things that none of us have chosen.
Mm,
We didn't choose to get older. We didn't choose to live in a society that dictates X, Y, and Z particularly. I mean, there can be some choices, but, and I think that's where the beauty of compassion focused therapy maps onto it, of, your kind of basic strapline of this isn't your fault, but it's your responsibility to kind of
mm,
maximize your best version of you within these limitations, within this
mm,
setting. And I guess there are
mm,
just potentially even more. You've got all of the challenges and difficulties of childhood and youth and working age adulthood, and then some, and then there's a whole heap more in later life. And
mm,
and I guess that's the beauty of why I enjoy working in that cohort, with that cohort. Um, is because there tend to be lots of things that you need to think about, and that complexity and challenge, it's
mm,
really rewarding to, it's a trite word, isn't it? It's rewarding, but but it's great to get up and go to
mm,
work and do something that you feel is meaningful, and
mm,
hopefully is received as being meaningful and useful
mm.
on the receiving end. But yeah, good.
I know in I think it's session 1 or 2 of compassionate mind training that there's a sort of a slide there about the realities of life, that we're born, we
Mm.
age, we decay, we die, sort of thing, like it. And I think it says
Mhm.
there we live an average of 25,000 to 30,000 days or something like that. And it's this little moment in CMT where it's a tricky sort of realization, isn't it? But it's not our fault. It's just how it's part of the design, and different people, kind of have different experiences of that life journey, and it's not
Mm.
it's not their fault, But how to manage it, I suppose, is the thing. What might be the spectrum, if you like, of challenges that perhaps you are working with this particular cohort?
Yeah, I was thinking about this, that I think that the spectrum is that everyone in society, as we go through an aging process, we face difficulties that have been created by society. So I think the biggest kind of overarching umbrella difficulty is ageism. And that affects everything from whether or not the person will even get a referral into services, so they might go to their GP, and the disconscious ageism, so that, something that somebody's not necessarily aware of can sit with us as health providers. So the patient may not even get a referral in because there can be an assumption that, well, this is just normal, of course you're going to feel miserable if you're older. Oh, well, there you go. And of course that's incorrect, that absolutely isn't the situation. But it affects referral rates, it affects, if you Google how much research is conducted on people of older age, the skew against actually creating research, providing research, is huge. And so you have this vicious circle of not really being able to go back to commissioners and say, well, this is the evidence base. This is really the commissioning that needs to happen in order to provide these kinds of really good quality services, because you haven't got the evidence base. And so, and everything's kind of created in terms of guidelines based on working age adults. And I suppose in a similar way to when you're working in child. So ironically, my thesis I did in pediatrics, so the complete other end of the spectrum. But when you're working in child, it's like, well, is a child just a small adult, and so therefore we don't need to actually adapt our interventions? Is that all they are? They're just a small adult in the way the Victorians kind of thought of. And at the other end of the spectrum, when you're thinking about working with older people, are they just working age adults but a bit grey? Is that all they are? Or actually, do we need to think really carefully about what this means and how our therapies are fit for purpose? Are there particular things that might come up as challenges? For example, if cognitive differences are a typical part of normal aging, and that's before you even think about neurodegeneration, then actually how are we adapting our therapies? So if we're thinking about, I don't know, processing speed being different, if we're thinking about theory of mind being different in older adults, or aphasias coming up, actually, are we adapting our therapy to be able to work with those people? Or are we kind of saying, well, here's my therapy. If you can access my therapy, there you go, good for you. Or am I making it accessible to? So, who's the person that's having to make the effort to change and adapt? And so we've got those kinds of things that I think are your headlines, if you like, of the ageisms and where that perpetuates and where it comes in. And that can also be internalized in the person that you're working with. So it's not uncommon at all for me to work with somebody who says, well, what's the point at my age in life? I'm not going to make any changes. There's no point. Go and work with somebody who deserves you more. I don't really need this. Regardless as to how much they're suffering. And you kind of sitting there thinking, do you know what's happened to you in your life story? You so deserve this. This is absolutely what's needed. And the beauty of being able to rewrite that next chapter, which is someone's final chapter, it's a real gift to be able to do that. And then I suppose the other challenges are the things that we've already tapped into and touched on of losses. So you've got your loss of roles. Often you're more likely to have loss of relationships, bereavements, those kinds of things. Physical health is likely to decline. You're likely to be more prone to be living in poverty. You're more likely to be suffering from loneliness. So those are the kinds of things that are sort of there as I suppose, an underlying difficulty that's probably going to affect a lot of older adults. And then you have the overlay of the severe mental health problem on top of that. And possibly then you have an overlay of sensory impairment as well. So actually it might make it really difficult for somebody to hear in the session or to navigate the waiting area, and then you've got your physical limitations, which might mean that the person can't actually use public transport or they can't get to clinic. And so then from the NHS, we can offer home visits, which is not a problem at all. It's absolutely fine. But the pragmatic issue around that is then you have your travel time either side. And so that reduces the amount of clinical offer that you have. And so again, if you're trying to commission services and saying, you've got, I don't know, 8 hours in a day, that means I can see 6 patients if they all come into me in a clinic. If you're working with people in we're like in a semi-rural setting here, and you're traveling out to people's homes, then all of a sudden you can only see 3 people in a day. So you've slashed your availability by half, but you're not necessarily going to get double the commissioning. So there's all those sorts of things, and it's a challenge kind of at every level, really. But
yes, I really appreciate you mentioning that first bit, the ageism, the biases really that we can tend to have for older adults, that somehow we feel as if it might be anxiety, but that's just a part of aging, or it might be that they're lonely, but that's just a part of aging, and we sort of really it's a very curious thing actually, isn't it, when you stop and think about it, but somehow sometimes that compassion for people at that stage of life even it shifts or something. There's less of a less empathy there, is it? Or is it something like that? Or is it still there's an empathy for older people, but there are just these assumptions that are at play? What's behind that ageism, that bias?
I'm not sure. I wonder if in terms of how we might frame things from a CFT point of view, whether there's something about distress tolerance. And when you're working with older people, you're kind of having a window into future self as well, aren't you? So to tolerate that, and I've had conversations with girlfriends who are not in the business at all, then just great old friends, talking about all sorts of things like anti-wrinkle cream, and actually what's the messaging behind that? The messaging very much from society is please try not to get wrinkly, because actually we really don't value that, and if you do, we'd really rather not see it. So there's something about it being a little bit tasteless to get older and to have needs, to have physical health needs. And I just wonder if some of it is, the work that, like when trainees come to me, the work that some of them have to go through, we all have to go through, of that self-reflection of, this is a version of how I will be in 20 years' time or in 40 years' time. And what does that mean to me? How do I sit with that and kind of bear witness to this future version of self. I think there's something about that. I think probably at the moment there's something about how enormous this difficulty is, you know, that we're in most Western countries, we're living with a, you know, a sort of an upside down triangle demographically. The birth rate is below, you know, what's above, and that we are going to have generations of people that won't be able to self-sustain, and what that will mean in terms of pensions. And actually, is there a frustration and an othering of, you know, you will become a burden on my generation? I don't know. I think, and all of this obviously is a kind of a disconscious level. It's not something that necessarily
Yes.
people cogitate on and go, you know, this morning over my cornflakes, I'm going to be thinking about, you know, the struggles of aging and why it is that I try and reject older people or whatever it is, you know. But yeah, it's a good question. Why do we do this?
It is, and I, yes, it's good to go back to the theory in a way, isn't it? And it does feel a little bit like it's sort of threat system activating for us in a way. It's a little bit confronting to
Mm,
think about it. It's a little bit confronting to think about aging and mortality, I suppose. And it's difficult because it's confronting from the point of view of yourself in a way, but also those you love and people around you who for whom this is all happening. And so we might sort of, yes, parcel it out a little bit as something other
mm,
in our own
mm.
way to cope really with some of the really tough realities of life. So where does CFT fit in for you? Like how have you started to think about CFT, compassion, self-compassion, sort of amongst older adults and perhaps across this spectrum of challenges that they face?
If we kind of thought about CFT in terms of the three circle model, and so where, you know, we've got the threat system, drive system, the soothing system, what might come up stereotypically in each of these areas? Why might some of those circles, if you like, grow, and why might some diminish? And so I think it has a very, so compassion focused therapy, I think has a very user-friendly interface. So I think it's very understandable to people that we're working with. And I've used it for people with significant brain injuries, with dementia. It's just very adaptable and very understandable. And for me, I like compassion focused therapy because it kind of taps into my historical training of sort of experimental psychology and linking and understanding with the brain. And I quite like to provide neuropsychologically informed CFT as well. But I think, so as well as sort of being able to map out the challenges and sort of understanding, I suppose, like we've just done, so we've had that conversation about the challenges, but then to map that onto the three circle model, so to help people understand why it might be that there are additional things. So in addition to their life story that they've lived with for very many years, that actually there are new things now that are tipping the balance. So it might be that somebody has strived during working age adulthood and kind of avoided their threat system by working really, really hard, and they've become incredibly successful in their own area of work. And that's functioned incredibly well. And then all of a sudden, you know, retirement comes or things shift, another generation replaces you. And all of a sudden you don't have a coping strategy by which to escape your threat system. And so there hasn't been an established alternative drive to work, for example. So that's, you know, a fairly simplistic thing that we can think about. But I think also compassion focused therapy offers some real opportunities about, well, what is it about aging that fits really nicely with CFT? And why might this be a good model in terms of strengths, a strengths-based model? And so I guess those concepts of wisdom being associated with elderhood is something that is quite easily accepted across a number of cultures and places that I would work. And so understanding that actually what I'm doing is I'm bringing with me to this therapy as a patient, I'm bringing with me actually a whole wealth of wisdom. And particularly when I'm working with older people, it's just so nice because that power imbalance is already redressed a little bit. You know, that literally, you know, stuff and you've lived through things that I haven't. You've had potentially decades more life and decades more wisdom. And so already there's that sort of power thing is a little bit easier to work with. So yeah, so I guess in terms of sort of your classic mental health intervention, I suppose it's not hugely different from what I would use with working age adults who have cognitive challenges. Um, but it might be more adapted than working age adults without cognitive challenges. So the pace might need to be slowed more. I might be providing a lot more in terms of handouts or slowing things down. Um, but there's some really nice pieces of work. I often use Play-Doh, and it can be. Do you know what I mean by Play-Doh? Like putty
Yes, yeah,
stuff. Yeah.
yeah,
Sorry, I suddenly thought, oh, is that just a British term? Um,
yeah.
and getting people to do formulations, their own formulations in the room with me with Play-Doh. And what that can start to do, so I had somebody I was working with recently who absolutely has been kind of defined by societies. You don't play, this is, you kind of retain a rigid persona, and this is not something that this person's ever been allowed to do, or certainly not at this stage in life. And so I have my putty Play-Doh pots and just said to the person, oh, I wonder if you can just try and, manipulate that a little bit while I'm getting these other two out, because I think that one's gone a bit hard. And the person just sat there in complete silence, squishing this Play-Doh together. And after a couple of minutes, looked up at me and said, I think adults should be allowed to play as well. And I was like, yeah, that's interesting. Where's that coming from? I wonder what's happening. And so sometimes you just get these sort of, moments of insight for somebody, and just a very quiet internal focus for that person in that moment in time. And now they've come back sort of week on week saying, oh, I'm noticing I kind of need to branch out. And it's a real challenge at this age, in somebody's kind of 70s. How do I start to grow and to kind of play in the way that I might be able to? And that person's been able to link back into kind of their own history and the culture that they've come from, and where that might be. They might be able to, instead of the focus on what wasn't available and what was missed and what was a poor opportunity in childhood and in early adulthood, actually looking at the alternatives. If I look back at these inheritances, these cultural inheritances, with the wisdom of later life, these are the things I can pick out and I can start to choose for myself. So some really, really lovely pieces of growth that you see. But yeah, and then I guess we've also adapted, I don't know if we've adapted, but kind of used CFT with groups of people with dementia. So I've did about 5 6 years, I think we wrote up of couples who'd got a diagnosis of dementia. So obviously one person had had the diagnosis. Typically the couples were husband and wife, but not always. So I had some grandparent grandchild couples come in, and within a group setting. So looking, and that was using a lot of compassionate mind training as well. Lots of visuals, so kind of that externalizing, but a lot of repetition visually and verbally. So if you're working with neurodegeneration, it's helpful to have that multimodal input as well. And then we've just finished our second group for people who've lived with trauma. So it's a kind of, these people might attract a diagnosis of personality disorder or complex emotional and relational needs or trauma, or so it's that cohort of people. And it was a really interesting, the second group, well, both groups have been very interesting, but the second group was very interesting because it ended up being just a women group only, just by default. And in the process of unfolding the therapy and unfolding stories, actually noticing that every single person in that group had had a history of very severe and significant domestic violence. Now, none of that had been on people's referrals, but there was something on the referral that felt like these people share something that might work within a group. And then in the process of unfolding that and making people feel, I guess, hopefully safe enough that they could share what, as much or as little as they wanted to, those stories came out, and it became just a very, very cohesive joint narrative of actually, this is what we've survived and this is how we've got through things. And using We used quite a bit of body work in that as well, doing sort of outdoor mindfulness things. And it was just, yeah, interesting what lands with different people and different groups, but it's been good.
Yeah, amazing. The three circles model is just such a wonderful practical model, isn't it? That feels kind of very helpful, well, across the age groups and so on. But it sounds like even that is somewhere to really start. To explore what's happening with the three circles as you go through these different life experiences, life changes, and so on. There's a little bit of pacing, structuring, kind of making things kind of practical. There can be little adjustments like that along the way, but creativity and playfulness really can be
Mm,
a part of it. I always, yeah, Paul Gilbert really says that, doesn't he? That compassion can be playful. And to
mm.
kind of incorporate that into some of your work, but the sort of the guided discovery Play-Doh. Who'd have thought that Play-Doh is a sort of a medium for guided discovery. There was that fellow and doing the Play-Doh, and there's this insight that comes to mind that
Mm,
that
mm,
um
mm.
that it's okay to play, sort of a thing, and then that becomes a big part of what happens moving forward. I do have some of your papers. The one you were referring to for couples with dementia, the evaluation of compassion focused therapy group for couples experiencing a dementia diagnosis. So I'll actually include a
Mm.
link to that paper. And it was, yeah, very impressive. 64 participants, so I guess 32 couples or dyads, and
Mhm.
very interesting results there. We did a study a little while ago of veterans and their spouses, and the
Sure.
veterans were lots of them were Vietnam era veterans, or
Mhm.
perhaps a little younger, and we just found there was something really powerful in the couples, both parties being present and being able to
Mhm.
kind of
Mhm.
learn together along the way and do some of the practices together and that sort of thing. That other study you mentioned, is that sort of still to be published? Is that
Yeah, I'm really keen to try to. There's like two papers following on from the dementia one that I'd
oh,
really love
okay.
to get those trainees to, yeah, to write up if I can. So one of them did some qualitative interviews with people after the group, and the other one, we looked at kind of the content from compassionate postcards that people had written to themselves at the end of the dementia for couples program, dementia in couples program, and they're just both beautiful little pieces of work. But so I'm trying to encourage those trainees to write up. And the trauma stuff, yeah, I'm keen. I guess there's always that thing in the back of my head, you're like, this is not as perfect as Kate Lucas, would do. And they have these fabulous, there's a lovely new paper that's come out, hasn't there? I think it's at Kate and Paul Gilbert and Fee Ashworth and people, I think. Um, so yeah,
Yes.
I don't know. It always feels a bit small fry, but at the same
Oh,
time, like I was saying at the beginning with the research not really existing for older adults, sometimes it feels important to try to contribute just a little bit. But
yes. Yeah.
yeah.
No, I managed to interview Kate Luker a few weeks ago, so I did hear about her study, which, yeah, she put a lot of time and energy and blood, sweat, and tears into that project, because it was a really big project and very,
Mm, mm, mm,
very important results. But I do feel that way too, that actually part of the importance and the novelty in your study is the cohort that you're working with, and that feels important too, I suppose, to get that
mm,
sort of
mm.
stuff out there. It's hard to publish. I struggle with it myself. Um, but when it comes to CFT, and you've mentioned a number of elements to CFT that perhaps really can work with this age group, but also when people, for example, are experiencing a dementia diagnosis and so on, it can be quite effective. What do you notice are some of the common barriers? I mean, if we think fears, blocks, and resistances, is that pretty similar kind of themes that you'll see? Is it a little different amongst the different age groups?
I mean, it's probably both and, isn't it? It's similar and it's different. So it's similar in that everyone's human, and you're going to have a lot of those same kinds of things popping up across each of us as human beings, and it's different because everyone's an individual. I guess as a difference between cohorts, maybe there's something about also that social messaging. So a young adult growing up in today's society may experience fewer shaming constructs put upon them than somebody would have done maybe 40, 50 years ago. So for example, somebody who's living with autistic spectrum disorder in today's world will probably get diagnosed in childhood. When I'm working with people in their 70s, it's very, very unlikely that they would have ever received a diagnosis or any conversation about living with autistic spectrum disorder. And so that obviously would have had to be explained by the social setting around them in some kind of way. So there's some sense making has to have happened. And that often is about blaming the person for being different or for being kind of not acceptable, or gender, very strong gender messaging that is different in today's society than it would have been. So women who would potentially have absolutely flourished currently just wilting because society said, well, you may do this particular thing, you may have these particular feelings, and this is what you may do. And a lot of shame around things like that, births outside of marriage, those kinds of things. Women still living where their babies were taken away from them, and that deep, deep loss compounded by deep, deep shame that was put upon them. So I think there are certain things that would have happened to people, rape within marriage, things that today's society defines differently, that laws are different to protect people in different ways. But I think there were potentially more opportunities for victim blaming and for living with situations that, were not somebody's fault, but were actually told to them, this really is your fault, this is your problem. So I think those things are probably different as a general cohort. And so in terms of like your blocks, it can be tricky to unlearn decades of what you've been told is right or is wrong. So that might be a little bit harder. But then, I could be wrong in that because, whatever age you are, you're 100% of your age, aren't you? So if you're 20 and you've had social messaging for 20 years, then is that any different from having social messaging for 70 years when you're 70? I don't know. But I do see a little bit more malleability when I'm working with younger adults. So like I said, I work with neuropsychology. So I do bits and bobs of medico-legal work and working with the court of protection and things like that. So I work with people from age 18 up. So I do have contact with younger people as well, therapeutically. And I think there's maybe some more malleability in younger adults than there is in older adults, but that doesn't mean it's not achievable. So it just means we need to just work around things. We might need to provide more external scaffolding in terms of cognitive flexibility. So possibly some of the techniques that are taught classically of being very open-ended, very open with your questioning is not as useful. So maybe providing closed questions and alternatives and options, and just very slowly bringing the person back to that point might be more useful. But yeah, so I think there are similarities as well in, so, the really useful, the big book that Paul Gilbert and was it Simos put out, was it like a couple of years ago? That's great, and it's really good reading for my trainees that are working in older adults as well. And then I guess we just need that little tweak as well to say, and in what ways it's just a little bit different. What else are we working with here?
Yes, there is really a lot of evidence around the role of shame and shame memories, isn't it, in terms of the fears of compassion and the fears of receiving compassion and the fears of self-compassion. And so sometimes that's one of the the big things we're working with. I was working with a woman sort of in her 80s recently, and she was recalling how, when she was little, her younger sister was the pretty slim blonde girl, and she was the tall, lanky, gangly, awkward one, and she still
Mhm.
feels it now, all of that time later. And it really struck me that those experiences get their claws in a little bit, don't they? And can kind
Mhm.
of hang around. She might feel somewhat differently about it now than perhaps sort of at other times in her life, but it's still quite painful for her, and it really is a source of the kind of the self-critical cognitive style, of feeling like she's
Mhm.
stupid and ugly and so on, and just that
Mhm.
feeling of shame and therefore, sort of undeservedness. So
Mhm.
it's that very powerful shaped by experiences piece, I
Yeah,
suppose,
yeah, yeah.
of compassionate wisdom.
Absolutely. And you've kind of got the double-edged sword as well, haven't you, in later life, that some people may have maybe living beyond when their parents are living. So that their parents have passed away and they can no longer have those restorative conversations, even if they wanted to.
Hmm.
However, given length of life now, we're now working with people who still have their parents surviving. So working with people in their sort of mid to late 70s who still have surviving parents. And the shame that can come up then of, I still feel angry and cross about things that were done or weren't done. But now I feel it towards these little old people who are very vulnerable at the very end of their life. And how can I hold that towards those people? And now I'm being a bad child, a bad daughter, a bad son, because actually I can't make that journey halfway across the country to go and look after them because I'm older myself and, frail. And so I think there's all sorts of challenges that come up that we're starting to see that, when I came into the workplace, we weren't working with people in their hundreds. And now it's not uncommon to have people referred in their hundreds into the NHS,
Hmm.
into the mental health services. And so we're, if we're working with like 65 to 105, you have got two generations, and at times potentially you've got even three generations in that age span. So I think we're learning as we're going, aren't we? And I guess that's what we need to do. I always think of Wallace and Gromit and that the cartoon where he's kind of laying the train track as he goes over it. And
Ah,
that's what it feels like when you're working in later life. It's like you're creating the evidence as you're just about to go over that piece of train track.
yes.
But yeah,
Yeah.
we have to be adaptable, don't we?
Mm. No, it is a double-edged sword. I see what you mean, and there can be a lot of, I guess, shame experiences now a bit as well, especially in and around grief or bereavement, as you mentioned, and difficult feelings of shame or perhaps guilt, in a slightly different way. So there's a lot, and really, people kind of really need and deserve, sort of assistance with that, to suffer less, I
Mhm.
guess, and that difficult piece around, like, oh, I don't want to be a burden, other people would be better off to see you, and that kind of that reluctance to receive the help. The on the one hand, the shame is such a painful, universal but painful kind of emotional experience, and we really need care and sort of
Mm.
connection and so on. And yet the shame causes us to sort of fear that connection or avoid it or push people away. And so we're sort of it's a double bind in a way
Mm.
with all of
Mm.
that. When you do the CFT, and I guess the dementia study was an example, but what is the role really, I suppose, of family or caregivers or other people in that person's life? How do you sort of involve others in the CFT process?
I think it's it depends on the situation, on the person. So with the group that I ran, there was a very clear role. It was for both people to come into the group, and both people were recipients of the same level of care. Um, and yeah, it's very much. So this is for both people in this room in time. Um, for other people, it's more of an individual delivery, but we'd be holding in mind the relationship around them. And for some people, it's very clearly that, you know, I'm going to the home of the person, and every time I go and see the patient, I see their relative as well. And I'm very much aware that I use the term patient, and I do it mindfully for very particular reasons. But I know that snags with some people, so I guess just to name that as well. Um, so sometimes, you know, you can't not have a session with two people, because that's where they are, and you know, they've maybe been married for 65 years, and there isn't really a me, there's an us. And so it's kind of working out how much space is there between these people, and is it useful to see somebody individually? Is it useful to kind of wrap your arms around both of them therapeutically and see them as a kind of a joint entity? And for other people, I would deliver a straightforward CFT to the individual. And then I've also relatively recently received some behavioural family therapy training, which NICE recommends specifically for people living with psychosis. So we now have a kind of pure family therapy offer. So sometimes I will work with the individual, and then we come to the end of that individual piece of work, and then we say, would it be helpful and make sense to bring the spouse in for just a few sessions of kind of going through that formulation, sharing the formulation together, and also some of these sort of communication skills that we learn and deliver with behavioural family therapy. And I've used that model a couple of times. Now, obviously, that model of CFT with a little bit of BFT on the end with the couple isn't, you know, it's not a research product. So it's something that I guess I'm aware, is this okay to flex? Is it all right to deliver, like, you know, a good solid purely researched compassion focused therapy, and then do some little tag on things on the end? So yeah, so that's now out there in the wide world, that I do these things that aren't actually research, but each of them in their own are. So
That's right.
I kind of hope it's something useful.
Yeah, and it sort of reminds me of the sort of the phase-based phases in therapy that Deborah Lee might talk about, where, you know, where it might be that initial compassion-focused therapy followed by sort of more trauma-focused treatment, you know, followed by reintegration, sort of, and it actually seems to make complete sense, to be honest, that would be a sequencing of the approach. For some people, the CFT might even be enough, and you might not move to that next phase. But
Yeah.
for others, it just feels really, you know, kind of worthwhile bringing the family in and having a kind of a family-based intervention as part of it. See, compassion-focused therapy, of course, was really developed to sort of aid in bringing a compassion focus to other interventions. So it seems like a very good idea. So if you were to think about some top tips, so I'll throw surprise you with this question slightly. But for someone perhaps who is themselves, you know, kind of, you know, in that perhaps older age group, or someone who is there supporting another person who's in that older age group, what are some sort of, you know, maybe a few little tips that you would suggest that could be helpful for people just getting started with bringing compassion or self-compassion into their lives? Anything come to mind there?
Mm. Well, I think I'd probably default back initially to Maslow's hierarchy, and I think just make sure that actually, you know, those basic needs are being met, because actually this is a lot of what we're seeing, is that older adults are being expected to live in situations that are not really meeting their basic needs. So, you know, I would hate to, and it happens, I hate to get a referral from a care home that says, oh, this person's presenting with problematic behaviour, and actually they're not getting any attention or any touch or any human contact at all. And then therefore they're not eating their food, and actually the temperature in the room's just completely wrong. So I'd probably go away from psychology almost initially and just say, is your body being looked after? Are you sleeping okay? And how can we sort out some of those things first? Making sure that
Mm.
someone is comfortable, that they're so in the UK, Katerina Reichelt and Ian James put together some lovely work for basic human needs. And, what is that? So kind of little checklist. So I'd be thinking of those things first. And then the kind of bringing that attention to myself and what I call the L'Oreal piece of work, first of all. So we had an advert over here a while ago from the company L'Oreal that said, because you're worth it. And sometimes
Oh,
that's
yes.
the front loading of the piece of work of you're worth it, you deserve this because you're a human, and for no other reason than every human deserves kindness and good treatment and to be cared for by self and by others. So maybe having to do that piece of work first of this is worthwhile doing it because you are worth it. And then I guess looking at your three circles in that kind of a way of how much fun is this person having? What are the opportunities for growth and development? Just because the person is 85 or whatever it might be, 90, doesn't mean to say they shouldn't continue to expand their world of experiences if that's something that they'd like to do. Again, like I've said, what are the person's opportunities for human contact and for touch? Because we know that many people live without being touched by another human for days and days and weeks and months, and that's kind of not okay. And as a society, what can we do? Can we keep challenging? I mean, I'm like a broken record when I go to meetings at work. I keep saying, well, is this suitable for older adults? Is this the offer that we're offering? And how are we making it possible? Why is it just on a digital platform? Why have you excluded all these people who don't have digital access? And so it's just that kind of keep challenging, I suppose, keep advocating for people at every stage of life. But particularly for older people who might have lost their voice. And that could be literally, they might have lost their voice through aphasic processes, but kind of metaphorically, maybe they've been silenced by society and can't advocate for themselves at all. And just, I suppose, we need to be opening our eyes. Who's invisible out there in our society and who isn't in the place they should be? So if you've got a waiting room, does your waiting room reflect the demographic of the people living around the area? And if it doesn't, who's missing and why are they missing? And what can we do to enable those people to come in? So, but I got invited to do a little piece into the Guardian, which is a newspaper over here, back in September. And I think the strap line they ran with was something like, eat your beans and scratch your own back or something. But it was a whole piece of sort of how do we manage physical health and mental health for people who are getting older, and what can we do as a society to sort of work towards that. So those things, and I guess those are things that come up sometimes in therapy. You'll say, well, how about in terms of behavioral activation? We start to do a walk to town, or you do an exercise class, and they'll come back maybe the next week and say, oh, well, my daughter doesn't like the idea of that because she thinks it might affect my heart and I might pop down dead, And you're like, wow, that's a really strong message to be given back. And I got out of breath. Now, if you're 20 and you get out of breath because you've exercised, everyone goes, oh, well done, that's great. If you're 70 or 80 and you get out of breath, people go, oh, don't do that. Stop. So I think there's a lot of challenging of our own assumptions as well. And quality of life rather than quantity of life, I think, is important, and where we can try to maximize that for people. But obviously that's with their consent, isn't it? Some people might not want what I think they want. So of course it has to be collaborative and consensual and all of those kinds of things. So yeah.
Yes, I think it's interesting that you started with the basic needs because, in a sense, it might not feel like psychology or clinical psychology, but it is compassion, isn't it? It's about identifying suffering and wisely identifying the sources of suffering. And sometimes the sources of suffering for people are at that very fundamental level of their life and their space that they're in, and their social world and their world of kind of care and connection and touch and those kinds of things. And so, in some ways, compassion in this area first and foremost needs to look at those the foundational aspects of their human life, and then from there, and well, even springing from there is this sense of you are worthy, you are worthwhile just by being a human being. You are worth it, and then from there straight into maybe sort of three circles type stuff. I love how you kind of brought in at that point, even got growth and flourishing. That compassion can be about flourishing as well, and what might
Mhm.
we do to just to really to support and bring opportunities for this person to expand their world of experiences. I think you said,
Mm. And I
and
think that,
then
that
hmm,
almost goes back to, oh, sorry, I was just going to say that almost goes back to the point you made right at the very beginning of turning 50 can be quite liberating. And
yeah,
I don't know if you've seen that lovely poem about, it's called something like Warning. When I'm an old woman, I'm going to wear purple. And it kind of goes into that I'm just going to, do the things I really want to do. And I think that flourishing maybe without quite as much responsibility as you used to have in younger life, it can be really liberating, can't it? That you can actually say, let's just throw caution to the wind. And what do I want to do with my final chapter? And
mm,
and so that can be really beautiful, I think. So
yes.
yeah.
Reminds me of the Mary Oliver poem as well, which I won't be able to quote, but what will I do with my one wild life? Or I think is the
Okay.
line. Yeah, and then of course, as a society, what can we do? What must we do, really, in a sense?
Mm.
And there's a role there for us, sort of an advocacy role, really, at every stage, but especially for older people. And like when who has sort of become invisible or who's missing from different, kind of times and places and that sort of thing, and how can we bring respect back to those people and to really support them to be heard and to be seen and to be valued and to be really supported in terms of just still having the kind of life that they can, but to be able to reach some of that potential for them, which varies of course, but that focus a little bit on kind of quality of life. I might put the link to that Guardian uh, article as well, for if
Mm.
people are interested to see what perhaps you suggested there. And I might try and find that poem. When I'm an old woman, I'm going to wear purple. So I've put that down, and I'll see if I can find that for everyone as well. If people were interested in being in touch or to finding out more about some of the work you're doing, is there a way for people to find you?
Yeah, I mean, people are very welcome to email, and I don't know whether you want me to like sit here and trundle out an email address or if you just want to put it in the
Put it
link,
in the
but people can
description.
either email, yeah, in my like my private work or through the NHS. So I guess it depends if it's sort of more collaborating around NHS stuff. So and
Hmm.
excitingly going forward, there's now a randomized control trial, which is sort of, it's not, I mean, it sounds very big-headed to say it's picking up from where I left off, because it isn't. They're doing this independently, but it's the compassion focused therapy for people living with dementia in groups, just as individuals, so not as couples, and looking at the impact of CFT on anxiety and depression. And so that's going to be a multi-trial study being led by UCL, so University College
Ah,
London. We're going to be one of the sites of delivery. So that's in the pipeline. And so there really
yes.
is stuff coming out. But I guess my plea would just be, yeah, please, do use compassion focused therapy with older people, and please do publish it. And, let's collaborate and get this, advocate and join up as joint forces and things. So, yeah.
Mm. That's inspiring to hear your work and to hear you talk so passionately about it. And sort of many of us have people we love dearly who are of older age. And if we stop and think about it, it really is a sort of members of our society that really are very important to us, and
Mm,
so
mm.
it seems like invaluable work to do. But Rebecca, thank you very much for being willing to come and chat to me on Compassion in a T-shirt.
Thank you.
Lovely to see you.